So good afternoon. Is this on, right? Okay. My name is Renata, and I'm from Purdue University, and I'm going to be speaking much more at a much more macro level. I'm going to be speaking about what I think industrial engineers can bring to healthcare. I'm going to tell you, give you two examples of some of the work I've done, and also I'm going to end the presentation by illustrating some of the areas where I think industrial engineers can help in healthcare delivery. So what do industrial engineers do? We are trained to look at very complex systems. We are trained to develop mathematical models and quantitatively represent what may seem like an incomprehensible system. And traditionally, industrial engineers have been found in the manufacturing, logistics, and transportation sectors. And especially since World War II, in these sectors of the economy, we've seen a lot of improvements in productivity and efficiency, and in large part because industrial engineers have been in these sectors. Just to give you an example, in a manufacturing plant, you'll have hundreds of different product lines, you'll have millions of different parts, you'll have very expensive equipment, you'll have specialists that use this equipment, you'll have downtime, you have staff scheduling. So it's a very, very complex system in which industrial engineers have traditionally worked in. In a manufacturing plant, you'll have process engineers, you'll have quality engineers, you'll have design engineers, you'll have industrial engineers, and these are all very technically skilled people, and their sole responsibility is to make sure that this manufacturing plant runs efficiently and effectively and is able to achieve high productivity. And what kind of the hypothesis is that healthcare does not have these people supporting their systems. And this is where I think industrial engineers can really make an impact. So I'm coming from the Regenstrief Center for Healthcare Engineering, and this is at Purdue University. And what we're really trying to do here is bring together kind of three aspects of healthcare delivery. First is the clinical side, so the nurses, the pharmacists, the doctors. Secondly, bring together the management and the economics and the business side. And then third, bring in the engineering and the science and the computer science component and look at how we can improve healthcare delivery. And I want to give you three examples of things that I've worked on. And one I'll go into greater detail than the other two. But I want to start with something I worked with the Indiana State Department of Health. And this was also a joint effort with the CDC. And what we're interested in is determining how we can best provide services, how we can optimally provide services in the event of a pandemic event in the state of Indiana. And Indiana is an interesting place because there is a large rural community, but there are also very large urban centers. There's Gary outside of Chicago, there's Indianapolis, so we do have this mix. And in this particular project, we looked at where we should put alternate care sites in the event of a pandemic and how to staff them. What type of equipment do we need? Recognizing that there's going to be physicians who are ill, nurses who are ill. But where do we put these sites that we can reach the maximum amount of population, and what equipment do we need and what supplies do we need within these sites? A second project that I've been working on is actually looking at clinical scheduling. So I was working with a clinic in inner city Indianapolis, and they actually had a no-show rate of about 40%. So 40% of their scheduled appointments would not come. So 40% of their scheduled patients would not show up, which of course has large revenue implications, utilization implications, and all that. So what we were able to do is statistically identify the factors of a patient that will indicate whether or not they will come to that appointment. So once we have identified these factors, what we can do is we can look at different types of policies. We can say, well, what if we double book, like the airlines? What if we overbook, again, like the airlines? What if we experiment with something called open access scheduling, so kind of a just-in-time approach to scheduling, which we've seen in manufacturing. And the nice thing about some of the industrial engineering tools is we're able to experiment a lot without actually going into the clinic and saying, hey, we've got a new scheduling policy. Let's play around with it in terms of mathematical and computer terms to see what happens. I'm going to show you an example of what I mean by mathematical and computer examples. So the third project I wanted to kind of mention, and I'm going to spend more time on, is modeling patient flow. And what I mean by what this project is what I'm particularly interested in is looking at the current state and the resource limitations of my hospital and make some sort of prediction about how these will evolve over the short term. So in English, what I mean by that is, let's say it's 9 o'clock in the morning on a Monday morning in a hospital. And I want to be able to know if at 4 o'clock in the afternoon I will hit an ambulance diversion. So that's when the hospital closes its doors in the ED and cannot accept any more patients because it's full. So I'm interested in making these type of operational predictions, these types of operational decisions. And once I'm able to quantify these decisions, I can make all sorts of different operational decisions, things such as staff scheduling. Which patient should I transfer? Should I call that should I call the ICU divert? Should I call an ambulance divert? Maybe housekeeping. Should I prioritize housekeeping? Should I tell housekeeping where to go? Maybe OR scheduling. So it's this type of short-term prediction and short-term forecasting that I'm interested in. And a lot of the bed managers I've been working with, they always tell me it's kind of a gut feeling. Like it's Monday morning, I have a gut feeling that maybe we'll go and divert this afternoon. So what we're interested in is actually being able to quantify that and make a solid prediction of, yes, whether or not you will reach that state. And not only that, what type of different policies can you put in place to avoid a state? And test these different policies in our models. So we begin by actually looking at the patient and understanding that the patient has, if we can understand how a patient will flow through the system, through the hospital, we can make a lot of sound predictions. And what we're doing is we're actually looking at HL7 messages. And HL7 is a protocol that is used between information systems within a hospital. So if a radiology system is communicating with the admission system, it's communicating with the pharmacy system, they communicate through a protocol called HL7. And our hypothesis is that these HL7 messages have a lot of information about a patient, and we can use this information to predict a hospital state. And to give you an example of what an HL7 message looks like, it's up here, but I can see that there's a lot of information. This, for example, William Jones, he was admitted, and it's an AO1 message, so that's what I can tell, at this particular time. So to give you, the hospital I'm working with, which is St. Vincent's in Birmingham, Alabama, they generate about 1 million of these messages every day. So there's messages for lab orders, for radiology, for diet. There's messages for vital signs, for lab results, for admission, discharge. So there's just this wealth of information sitting there, and it's all in the communication between different systems. And the beauty is a hospital doesn't have to have an electronic medical record system to have this information. All hospitals in the United States, and probably for most of the developed world, have these HL7 messages floating around. So what we're interested in doing is taking these messages and creating an expected pathway for a given patient type. So what I'm trying to say is I've gathered all this data for, let's say, DRG 558, which is a cath patient. What I want to be able to do is say, this is the expected path a heart cath patient will take through the hospital. At 9 o'clock, they're going to come in. By 2 o'clock in the afternoon, I expect them to use an X-ray. By 3 o'clock in the afternoon, I expect them to have an EKG, and so on. So I'm beginning to develop these expected pathways for a patient type. And the next thing I'm able to do is I'm able to build a mathematical representation of a hospital system. And I can feed these expected patient paths into a model of a hospital system. And this is done with something called Petri nets. And the nice thing about Petri nets, it's a form of graph theory. And it does look kind of funny, but this is a hospital represented as a graph. And the nice thing about it is I can use equations to represent a system. And with a simple set of equations like this, I can make predictions about this is where I am, this is where I may be, and this is what I want to avoid, and what can I do to avoid these steps. And it looks kind of simple, but I think it is a different way to represent a hospital and what happens in a hospital. So where I think this can come in place is we're able to look at things like bed availability at any given time. We're able to evaluate, and I know you can't really see these numbers, but we're able to evaluate the cost of certain types of operating policies. So I can see, maybe I can look at my bed availability, and then I can look at, well, what happens if I bring in more housekeeping? What happens if I let these nurses work overtime? So we're able to make these types of evaluate these types of short-term operational decisions. And I think this has a lot of implications for resource management at a hospital, for flow optimization. And what I mean by that is avoiding those bottlenecks in the ICU, in the emergency department. We're able to have kind of short-term decision-making ability. So we're able to kind of identify whether or not we will have a bottleneck. An interesting thing that's come out of some of this work is we're able to look at variation in clinical practice. Now, because I'm able to develop these kind of expected paths that a patient of a certain type will take, what's become interesting for some of the nurses I'm working with is examining if a patient, let's say a heart stent patient, begins to deviate off that path, and why are they deviating off that path. And the other interesting thing that's come out of this is patient safety. One thing I've begun to notice is, for example, a lot of lab results are coming back after the patient is discharged. And what are the implications of that? So that we have this data available, and what I'm saying is we should use it. So just to summarize, as an industrial engineer, these are some of the areas where I think we can have a large impact on healthcare delivery, and I just wanted to bring them up, and I'd be happy to answer your questions about them during the panel. One area that I'm really interested in but haven't done a lot of work in is looking at care coordination for chronic care patients. So again, we have this information of what they need, when we expect them to use it, and can we better coordinate our services, again, to reduce cost and things like that. I'm interested in avoiding divert. What types of policies can we put in place to avoid divert situations? Surge capacity, medical errors. Also, as an industrial engineer, I'm very interested in identifying performance measurements for a hospital system. We do it in manufacturing. We know how our lines are running. Why can't we do that in a hospital? Another area where industrial engineers do quite a bit of work is in facilities planning and layout and design. And could we bring some of those tools and technologies to a hospital or healthcare or an outpatient setting? I'm also interested in scheduling, optimal scheduling. And a big area which I don't think a lot of people actually think about is inventory management, keeping track of that inventory, when to order it, and again, that's very costly. So to summarize, I think industrial engineers do have a lot to offer for healthcare delivery, and I hope to see more of them in the hospitals. So thank you.